don't get the surprises in clinic, right? Like, what's happening in between visits, and you don't get that, oh yeah, I had to cancel my last one, and I'm here now because I fell during my pickleball game and like was too sore to come in. Like, oh my gosh, right? Like I haven't seen you for 10 days and that's what happened. Like that's terrible on a variety of fronts, right? So it's bridging the gap. It's creating that connectivity in between visits.
I'm Garrett Salpeter, and I believe that the most powerful and transformative way to help people recover from pain and injury, heal from trauma, and reach their highest levels of fitness and performance is to focus on the nervous system. In this podcast, we'll share knowledge from the frontiers of neuroscience and inspirational stories of how applying that knowledge has empowered people from all walks of life to heal, adapt, and grow. Welcome back to the Undercurrent podcast. I am joined today by Steven Coen, the co-founder of SaRa Health. And at SaRa Health, they are offering a remote therapeutic monitoring platform and solution for clinics. And it's something that I'm very interested in because it allows practice owners to become more efficient in their communications with patients between visits. It allows them to deepen and maintain their relationships with patients, which of course can help more patients complete their plans of care and have a better overall experience. And it also allows practices to bill for some of that extra communication that they're already doing. So it's a really cool system. And it's something that I've connected with Steven at several events. We've gotten to know each other offline, and I invited him onto the show so he can share what he's doing with the practice owners in NeuFit Nation. So perhaps you find something that you want to use here, or it inspires you to do something differently in your business. Whatever comes of it, I'm excited for you to listen in and hear what Steven has to say. So thank you everyone for tuning in, and thank you, Steven, for joining us.
Oh, Garrett, thank you very much for having me. It's a blessing, and I'm excited for this conversation.
Awesome. Yes. Well, let's dive in. So I definitely want to talk about the process and SaRa Health and what you're doing for practices. Before we do that, can you tell me a little bit of the origin story? How did SaRa Health come to be?
Absolutely. So I'm a frustrated patient. I'm not a clinician, but I've seen a lot of y'all. So I like to joke that my parents gave me some pretty good genes, but ligaments and cartilage were not included in that pool. So I've had ACL meniscus reconstruction, I've had labrum repair, and my exercise of choice these days is Olympic weightlifting. Not at the Paris level, but we do have one. Actually, we sponsor an athlete that'll be there this summer, and pretty excited for Mary to perform well. But it's not if I get physical therapy in a year, it's when and how much. And so being with those amazing clinicians for as long as I have, I was so frustrated by the lack of continuity in between visits, where it felt like I was starting and stopping every time I went in and then respectively left the clinic. And so that's where the whole idea behind SaRa came from, was let's help bridge the gap in between visits. So myself not being a clinician, I knew that was not a good way to start a healthcare technology company. Found our co-founder, Paul Urhat. He's a DPT, has been treating patients at the Mayo Clinic for about a decade, and his drive was around, he has so much data at Mayo to be able to treat. He wanted to level the playing field, whether you're in Rochester, Minnesota, or Shawnee Mission, Kansas, or LA, like wherever, and level that. And lastly, our CTO, he and I met. He was getting his master's in computer science at UCLA. I was getting my MBA, and we met in a class called MedTech Innovation. Go figure. And that's where the brain trust, if you will, came from. And our CTO, he's a big runner, also frequent physical therapy flyer. And so you had this really nice coalescence of passion for the industry and passion for the patients that led to us starting it about 7 years ago.
That's awesome. I love that. A couple of things I want to highlight there. One is, it's cool that I want to hear more about the Olympic athlete that you're sponsoring there. We've had a lot of cool stories of Olympians working with practitioners in our network using the newbie for rehab and training. And we've also worked directly with the U.S. men's gymnastics team, which by the time this comes out, I think the Olympics may have already happened. So hopefully we'll have seen them do well and be successful. But it's been very cool. Some really cool stories coming out of that, including this guy Brody Malone, who had a just horrific knee injury he was landing a huge jump coming off, in the gymnastics, right? So he's coming off the bars and landing from 10 plus feet, and he landed on the edge of a mat and he blew out literally everything in his knee and had this injury of like no one's ever come back from this and competed in gymnastics. And 11 months later, because he's in large part because he's been using the newbie, and has this he's also on here and telling his story. So I'll refer back to that episode, of course. But had this amazing comeback, and it'll be really cool to see how that story concludes at the Olympics. So I just wanted to touch on that. Also, a great lesson hearing you speak, a great lesson on formulating business partnerships or diagnosing issues in partnerships. I hear a lot of people have successful partnerships, also a lot who don't. And one of the biggest issues is having that balance of responsibilities and skills and activities. So to have you, that wonderful trifecta of the business person, the clinical person, and the technology person there, because you need all three of those in your business. And so, if someone's better at, in a physical therapy business or a chiropractic practice, if someone's better at marketing and promotion and someone's more clinically minded, those different things, having those complementary skill sets is so important. So I just want to call that out because I think that's a good business lesson. And thankfully here we're learning from your success rather than from the failure, right, of it not working.
Well, Gary, there was at one time a fourth co-founder, and there's no longer a fourth co-founder. So there were some duplicative skill sets, and the passion wasn't there, and so we had we parted ways relatively early on, and that was ultimately for the best. But yeah, so I'm pretty happy that we went 3 for 4. That's pretty good, but by no means were we perfect out of the gate.
Well, I didn't actually know that. I didn't mean to bring up any of that, but
I told you to be transparent, and learn from my scars if you can.
Yeah, I appreciate you sharing that, and that is I've had issues along the way for that same reason of just not getting that balance right of the right skills and sharing their responsibilities and skills and dividing up the equity accordingly. All that stuff. There's a whole business discussion to be had there. So I just wanted to call that out. So you said there's three co-founders now as it stands. You've been around for 7 years. Can you talk through the timeline there during that 7-year period? So, I think a lot of people, remote monitoring had been a thing before COVID, but during the pandemic, a lot more people became aware of it because it became such a big deal. And then now people are still aware of it. I think there's some questions about whether it's going to continue to grow, whether has seen its moment and is in the decline. Can you talk through your history, leading up to COVID and then now? Just give us a sense of what this remote monitoring field is like overall.
Absolutely. And on that, I think for a knowledge set for remote therapeutic monitoring, what we see today, which has been shifting more into more people at least knowing, but gosh, I'd say somewhere probably between 40 and 50% of practice leaders we talk to still don't know what these codes are. Like at a knowledge level of 0, we like to say that the knowledge level of -1 is when we hear of like, oh, this is like telehealth. I'm like, no, it's not. And we got to get them back to 0. And then, that's probably 5-10%. And then the remainder actually either know about it or are billing about the code. So it's still very much a very, very, it's in its infancy, I would say.
And just to clarify, so can you clarify the difference between remote monitoring and telehealth, and then also the difference between RPM and RTM, and so can we just to make sure we kind of are speaking the same language and have the same understanding of these terms also?
Yeah, absolutely. So telehealth is that synchronous visit with a patient, right? Typically over Zoom or some other video conferencing type of medium, and so that is in replacement of an in-person visit, right? Like, hey, we're going to do this via telehealth because you can't come in or don't want to come in, whatever the reason why, but it is meant to replace the in-person visit with a telehealth visit, right? When you look at the remote monitoring code, so back in 2018, Medicare came out with remote patient or remote physiological monitoring. And that is only for physicians, so MDs, NPs, PAs to prescribe. It has to be a hardware device, so blood pressure cuff, Garmin watch, right? You could name just different physical device there. And even with those constraints, right, on them, what Medicare estimated they saved in 1 year. So they released these in 2018. In 2019, Medicare believed that they saved about $6 billion with a B, $6 billion on COPD patients alone, just looking at reduced admissions and readmissions, because they were able to get ahead of things when they saw, weight fluctuations, heart rate variability that they didn't like, right? All those things, which really went to support a relatively easy to hold assumption, which is if you can get ahead of something, it won't be as bad, right? Like, it's not exactly rocket science for how Medicare and now the commercial payers are looking at it. So 2018 all the way up until January of 2022, that's when they released the remote therapeutic monitoring codes, which is what we help facilitate. So those codes came out on January 1st of 2022. And the key differences are that it can be any qualified healthcare practitioner. So PTs, OTs, COTAs, PTAs, right? Therapists and assistants. They can use a software as medical device to be able to collect the data. Other than that, the rules are pretty much the same. And the RTM, so the remote therapeutic monitoring codes, are limited to the musculoskeletal system, hence why it's so popular in PT and OT, respiratory and cognitive behavioral therapy today. Now, they started out with respiratory and musculoskeletal in 2022, added cognitive behavioral in 2023, and so I think, and then in 2024 they didn't add a system, but they opened these codes up to be billed by federally qualified health centers as well as rural health clinics. So it just every year there seems to be an expansion of this. And then on the commercial side, we're not quite to unanimous coverage by any stretch, but we continue to see commercial payers get on board. And I think by 2026, it'll be pretty darn close to unanimous coverage for these codes based on what we're seeing. I mean, United, Aetna, Humana, three of the big national players that all pay for these codes. Then the Blues plans are very state dependent. So Louisiana does not, but Tennessee does. Let's see, Arkansas does not, but Minnesota does. It's very dependent. And even we found, I think the weirdest one, in my opinion, is that TRICARE does not, but TriWest does, and the VA does. So I don't know on that, but that's what we've seen on that, and how that relates to our origin story is the way that you get paid, that you can really make these codes work for you, is by getting the highest level of response rate from your patients for whatever software as medical device you're using. Now, we weren't in the insurance fee-for-service world when we came out of the gate in 2017, 2018, because we realized relatively quickly that we might threaten the number of in-person visits, which back in 2017 wasn't really something that the insurance-based practices were willing to play around with, right? A lot of macro differences beyond just like COVID and everything else back in 2017. But what we did find were there were these PT and ATC groups that had direct contracts with employers, and they got paid lump sum, and all they cared about was how can we deliver the most care in between visits as possible, because they were highly, highly financially incentivized to do that, right? They just simply, the more visits something required, the less margin they made. And so they're like, yeah, like we want to see a 60% response rate, and that's what we're held to. And we did have a home exercise program app and web app and everything for our patients to start with, but what we found was the engagement we could get was just so much lower than what the bar had been set at. And so we started to ask a lot of these firefighters, hey, why don't you log in except for once every 3 days and da 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 da. And the response was, well, I'll log in when I'm here in the fire station on shift, but I don't have a smartphone, or I'm not going to get on my wife's or husband's computer, right? What have you. And so I remember in a bit of a bout of frustration with Danielle from Plainfield Fire, who had written us a review, like just an amazing recovery story on her end. And I was like, why don't you log in? You say you love this, it's so helpful. I was like, oh, well, I don't need to. I got it. Okay, well, what if we texted you? It's like, well, it better be a good text. And that was the start of basically our pivot on the technology side as a company. And then when these codes came out, we had already been experimenting with how to engage with patients on different, depending upon where they're at in the recovery cycle, what they're being treated for, right? All of these things, we had a really nice head start. So when the RTM codes came out, and we're like, wait, the highest margin code for a practice is if a patient responds 16 days in a 30-day period. Like that's all we've been focused on for the last 5 years. Yeah, let's just do that. And pivoted the company in May of 2022 and haven't looked back.
So as you were speaking, I was formulating in my mind, kind of a follow-up question there. I think you may have just answered it at the end there, talking about, 16 days out of 30. But to the degree you can generalize among all the carriers and all the contracts, is there a set requirement for what level of interaction or what a clinic has to do to meet the RTM, the remote therapeutic monitoring code? And is it by week, by month? It sounds like it's by month, but can you just kind of talk about what it actually is? If you're talking about, reimbursement rates and codes, what are the boxes that need to be checked in order to legitimately, ethically, correctly bill that code?
Absolutely. So while there are some documentation differences across the different payers, luckily the rules are all the same as we've seen. So there's 4 codes. The easiest or the lowest bar, as we say, is 98975. We call that the Connect code. And the requirement there is that a patient be monitored for 16 days in a 30-day period, right? So that doesn't have an engagement level requirement there. It's just simply, did they consent and continue to be monitored by whatever software medical device you use? If so, check. You're able to bill that. It's a pretty low bar. We're about depends on the practice, but like 87 and 92% of patients enrolled on SaRa meet the threshold for 98975, and it pays about $18 is the Medicare national average. And so it's a low bar with a relatively low reimbursement to it. But hey, even on a 6-visit script, right? Like add an extra $3 in revenue per visit is not a bad day, right? If you're to be able to get that by simply turning on something new, it's not bad. But that's not the level that we have our practice shoot for. It's 98977, which is, we call it the Engage code, and that's if a patient responds on 16 unique days in a 30-day period. And that is billable basically as many times as you hit that threshold, as long as there's an active plan of care. So we see practices that, like I think of one of our customers, Chris Gordos of IMG PT. On average, he bills 2.1 98977s per patient enrolled. So with an average Medicare reimbursement of about $48, that means he's adding a little over $100 per patient per episode by using SaRa, right? So real money getting into the $7 to $12 in additional reimbursement, additional revenue per visit, right? For those. Now, Chris has really made this his own, and we're working on pushing some of those best practices back to our other customers, not too dissimilar to what you're doing, right, with your mastermind group and others, and trying to bring those best practices and translate them across to everybody. But those are the 2 codes that we really focus on. There are 2 more that are time-based. So spending 20 minutes with supporting a patient in between the visit, there's a couple other pieces there. Like you have to have a synchronous interaction, which is most likely going to be a phone call. And you also have some level of influence on clinical decision making, right? So either maybe you added an exercise, maybe you took away some exercises, maybe you decided to bring them back in for the newbie, right? Based on how they're reporting on SaRa. As long as there's an influence on clinical decision making, right? Those are the requirements for those, but we don't push for those. We tell our practices to not actively try for them. There will be opportunities to get that, but that's, to me, that's just really not where you're going to be successful, because then you have to think about, okay, well, where am I going to grab an extra 20 minutes of time from my clinician, right? That's already potentially double booked. It's just not. We don't think it's scalable or really applicable to most of the practices that we work with.
Okay, so that practice owner there who is doing, one of your power users that's averaging 2.1 months of that per patient episode, what would he say are, in addition to making an extra approximately $100 per patient episode in insurance reimbursement, beyond that figure, what would he say are the biggest benefits to the practice?
So I know a couple of things that he's remarked on is you don't get the surprises in clinic, right? Like, what's happening in between visits, and you don't get that, oh yeah, I had to cancel my last one and I'm here now because I fell during my pickleball game and was too sore to come in. Like, oh my gosh, right? Like I haven't seen you for 10 days and that's what happened. Like that's terrible on a variety of fronts, right? So it's bridging the gap. It's creating that connectivity in between visits. And while I am not going to claim that we do have any sort of time savings at this point, what we do hear a lot is that the subjective portion of the visit is much more efficient, because you don't have to ask, hey, how have you been doing since we last saw each other, right? Because you know that the pain has been trending like this, or home program adherence has been trending like Y, or of other key events that have come up that the patient has told you about via SaRa. So it's you don't have to ever ask the question of how's it been going since we last saw each other, which no one likes to get asked, and I'm pretty sure no one likes to ask it either. So that's a side quest, is to kill that question once and for all for everybody.
Thank you so much for listening to the Undercurrent podcast. If you're interested in learning more about how NeuFit and the newbie can impact your life, please visit our website at www.neu.fit, that's neu.fit, so you can learn more about how it might integrate into your professional practice, how you can use it as a patient, and you can also connect with our team there. Okay, so that's the big, just sort of streamlining. You can know surprises, you can know how to optimize whatever the patient's doing. I know you said you don't recommend doing the extra 20 minutes and having a call there, but in that text back and forth conversation, which I want to get into the details of what that looks like from a clinician side, but before we do that, are they going to be using that as an opportunity to make changes to the home exercise program? I mean, what's the content of these text interactions like?
It's very dependent upon the patient type. So we have 30 or 40 different patient types and we call them flows. So a patient that is being treated for outpatient ortho exercise focus is one of our patient types. And so that would be maybe a total knee, right, patient that would get that flow, that experience. And of that, around 50% are going to be questions related to the home program. And so it can be about, did you do adherence? It can be about, did you do all, part, or none? Also home program applicability. So are these taking too long, too short, just right? So the Goldilocks question, as I call it, is one of my favorites. We get really good answers from that one. That's one of our highest responded to questions. And it makes sense, right? Like, how many times have you been a patient and gotten the 6 exercises and be like, of course I'm going to do it? Like, no, there's not a chance, right? There's not a chance. And giving people the ability to say that in a non-confrontational way, right, is really powerful. Then there's going to be we run on basically like an 8 to 10 day cycle internally on specific data points that we're going after. And again, very dependent upon the patient type, right? For the outpatient ortho, it could be pain, confidence, more like adult daily living, right? Like, how are you able to perform those ADLs? For our vertigo patients, it's going to be around dizziness, falls management, right? We have a specific falls and balance. For like, we have TMJ. It's quite a few others. That'd be our chief clinical officer could have a deeper conversation about that. But what it is looking at both the home program, right? Whether that's a home exercise program or just simply a home program, right? For maybe like more of like a neuro based patient, and then tracking very specific variables that are going to be helpful to the clinician in understanding where the patient really sits in their recovery.
Okay, yeah, that helps me understand seeing that range of use cases for sure. So if I'm a clinician and I'm adding this in, what is the experience like? I mean, it sounds like with some of these workflows, are some of these automated? Do they come into a cell phone as a text message? Do they come to the computer? Do they come in through the EMR? Like, how do I have these interactions if I'm a practice owner or a staff therapist?
Absolutely. So what we've done is created a Google Chrome extension that lays over the top of about every web-based EMR out there, at least the major ones. So if you're on Prompt, WebPT, whether that's SOAP 1.0 or 2.0, NetHealth, Empower EMR, Clinician, there's like another 10 that we're on, Athena, ECW, and others. As a clinician, you never have to go to a different tab. So have this little thing off to the side, the SaRa logo, you press it, boom, your patient list comes up and you're able to see everything that the patients have said and send custom messages that go out. So to answer your question on the clinician side, yes, it's text messages to the patient, but no, your personal cell phone as a clinician is never tied to this, ever. Like, it's not connected whatsoever. So there's some separation between church and state there that we hear is very much appreciated by a lot of the clinicians who have been giving out their personal email or cell phone number for years or decades, right? That doesn't need to happen anymore, and it can keep the same level of intimacy, that really nice medium, without sacrificing your personal contact information. And so that's how it is on that. Then the PT or the clinician will have a billing page that will generate the documentation for them whenever a patient is billable. So copy paste it in the EMR, bill it out, and you're done. And what our system does as well is takes into account all the different data points and requirements for the different codes. And as you bill and mark it as billed, we're running an algorithm to make sure that we don't serve you up codes that would get denied for more or less an administrative like snafu. So we do all that for you, tell you when patients are billable, copy and paste it, and you're good to go. And then from a administrative standpoint, the vast majority of our practices now are having front desk or other administrative resources enroll the patients. And so as a clinician, you don't have administrative burden when it's run well, which is, again, the vast majority of folks that we work with. Because that's one thing we found, and I'd be curious to know your thoughts on it too. The amount of patients with a C, not a T, S, the amount of patients for clinical burden and data and new data is extremely high. The amount of patients for administrative burden by a clinician is absurdly low. And so that's been what we found, and where we just anytime, every time we can get administrative burden out of our system, we do it either through people, process, or technology. and the additional clinical data that we are collecting, that seems to be worth it if there is any additional work for the majority of clinicians and practices we work with.
Right. Yeah, that makes sense. And I would agree with that. I mean, we want our clinicians to be able to focus more in their zone of genius, be able to do more clinical stuff, not have to be distracted as much. Notes are already, oftentimes a burden. So to add on something else can be, can be a little overwhelming. So I appreciate that. I agree with that perspective. In terms of this, then, on that, the time investment here, the burden, whatever you want to call it, is so the clinicians getting text messages, they can pull it up, so they can respond between sessions at the end of the day, check in with patients. So that part makes sense. Since you mentioned these workflows, are any of the outgoing text messages to check in, are those automated, or do they have to?
All automated.
Okay.
Yep. You set it, and SaRa runs.
Okay.
So if you were a patient, right, come in for your eval, the front desk is going to enroll you based on what you're being treated for, or what the clinician says. Hey, I want Garrett in my vestibular flow, right? Like that's what so I'm treating him for. And then from there, SaRa is going to text you once a day with a question that you can answer in one character or one word. So extremely low calorie and friction for the patient to be able to respond. And then that's how we generate the data that comes back, and we're analyzing those questions on a daily basis. Now that we've sent, I think, over 1 million messages, which is a wild number. Over 1 million messages, we've learned a lot about what works and what doesn't, and we're still learning every day on that front. We're nowhere close to having that solved yet, which, thank goodness, that'd be boring if we'd already had it figured out.
If all the world's problems were solved, right?
Well, what do we do? Yeah.
So are there times when, if I'm the clinician using this, if it's just like, have you done your exercises? Yes or no. Have you had any additional issues? Yes or no. If they have the answer where everything is just okay, status quo, do I even need to do anything, or does it only sort of come to me if there's anything that I need to process or respond to? Like, what actually comes to the clinician then in this workflow?
So you're able to see everything that SaRa sends and everything the patient sends back at any point in time. But to answer your question, we don't send basically a hard notification to a clinician unless the response is non-standard. So every question that we ask has a set of expected responses from a patient, and anything that's outside of that is a non-standard response, and we will alert a PT or whoever the primary provider is on that case if a patient says something that is non-standard. So with it's funny how the Pareto principle plays out in real life, right? So 80% of our responses are standard, 20% are non-standard. Like, it fluctuates between 81 and 19, and like it's so crazy close. It's kind of hilarious. And then within that, 80% of non-standard responses are what we call elaborations. So it'd be a question like, and to actually use one of our favorite examples, a question went to the patient, hey, please let me know your pain on a scale of 0 to 10. Reply, 0 through 10. Response came back, 2, because Lucy, you're a genius. Lucy is this patient's PT. That was the response. She got it. She smiled. She went back on her day. We ended up forwarding that to the ownership group of that practice, and then they mentioned it on their next weekly staff meeting, and put it up on the board with like just a slide that just said that, which was really cool, like a really cool moment. But it's about like the Pareto principle, like 80% are going to be standard, 20% non-standard. Of that, 80% are going to be elaborations, and then so that comes down to about like 3 or 4% of questions or responses are going to be something that are probably needing some level of thought, right? It could be, I didn't do all my, I'll use another example, none on vacation and don't have time to do my exercises. And PT got that, responded back with, well, could you at least do this one stretch while you're gone? And then we were like, ooh, this could be fun. We're going to track this one. And sure enough, like 2 days later, responded back with basically like, I've done them all. Like I started that stretch, and then by the time I was done, I was just like in the mood to go do the rest of my exercises. I was like, man, that's cool. Went from losing a week, right, to not only creating a stronger relationship, right, with that nice like push pull and that tension, but also what is likely going to save the patient a week on their recovery time.
Yeah, I think that's another benefit too. I mean, I mentioned it on the front end, and have it's come up even if we haven't named it directly, but that just that sort of deepening the relationship, having that accountability, having more interaction, it keeps the therapist top of mind. So I don't know if you have statistics around it. I would imagine it helps with retention rates, arrival rates. I imagine when you're interacting with someone, they're less likely to skip their next appointment or no show, right? And stuff like that. Do you have any
We do have
data
a little
around
bit on that. Yeah, we have a little bit on that. So what we're hearing right now is that we'll call it on average, the cancellation rate is dropping by about a 1 to 3% chunk, right? So you're going from 10 to 9, you're going from 12 to 10% cancellation rate within a 2-month period of putting in SaRa. So we're seeing that. We've done an outcomes study where we looked at the functional outcomes using photo for a non-SaRa control group versus a SaRa group, and found that the SaRa group achieved over 14 points higher than the control group on the photo expected outcomes, right? So instead of getting to 50, they're getting to 64. And so the patients are getting better outcomes, which is really, really cool to be able to see that. And we have some data around increased, or not increased necessarily, but a higher rate of compliance with home program, where 62% of our patients report that the text improved their compliance to their home program. There's also like 18% that say the text didn't help me because I was going to do it perfectly anyway. I'm like, all right, maybe give us another like 9% there, right, to get us above 70. But to answer your question with what I think it is, and now this is a debated topic within SaRa, so if you talk with Paul, our chief clinical officer, he probably would have a different opinion on it. But 81% of SaRa patients report a higher perceived value of therapy because of the access and the check-ins, right? And we operate on social contracts every day, all day. And if I feel like I'm getting more out of something, I'm going to reciprocate, right? And so I think it's that as the underlying foundation that is the tide that raises all boats, is simply that patients feel more value and therefore reciprocate with more energy on their side.
Yeah, that's great. And it's interesting hearing you say this. We have some data from pilots with different physical therapy groups that when they use the newbie, the arrival rates are better, retention rates are higher, cancellation rates go down, net promoter score goes up. And to hear that you're seeing similar improvements and effects with something that's totally different is fascinating, and also makes me wonder, what about the combination, right? Doing, improving the in-clinic and then also improving the between visit experience. But it all makes perfect sense. If you're deepening that relationship, and that is, a great recipe for better outcomes and better experiences overall. I mean, like you said.
Do you want to hear a crazy stat on that?
Yeah.
So Dr. Tim Marshall, who is at Ivy Rehab, they decided to run an analysis of basically performance metrics against patient satisfaction. And lo and behold, it was on almost a perfectly correlated line. He's like, that scatter plot was so stinking tight, where if patient, like they could basically like rank patient satisfaction number one, all performance metrics number one. Like it was just such a tight line. He said it was wild. So if it's true for Ivy, I would have to imagine it's true for a lot more than just Ivy, where, to your point, the patient satisfaction is higher. A lot of other things are just going to take care of itself.
Yeah. It also reminds me of one of Malcolm Gladwell's books. I want to say Blink, it might have been a different one, but he talked about how, doctors and malpractice lawsuits, that the same type of medical issue could happen. There could be a botched surgery or poor outcome, and the the same type of thing could happen, but the doctor was a lot less likely to be sued if he or she had better bedside manner and the patient actually liked the doctor, versus if the
Yep.
doctor was more cold, patient didn't like the doctor, they were far more likely to be sued. And there was a huge statistically powerful connection between how the patient felt about the doctor and how likely the doctor was to be sued. It was fascinating, but just another example of that same premise.
Yeah. Oh, exactly. Just flipped in more of the like the downside, right?
Yeah, right.
But yeah, that is an amazing stat. I've seen that one too. That is wild,
Yeah.
wild.
So you've certainly gotten me intrigued in the concept here. I imagine many people listening to this are also at least understanding the concept. Perhaps it's inspiring them to look differently at ways they can interact with patients between visits and deepen those relationships. If someone is interested in exploring SaRa, can you talk about what's the investment, what your business model, and then of course how people can connect with you or the appropriate person on your team, and just let us know some of those details as we wind down here.
Yeah, absolutely. So there's an investment, but it's not monetary to start working with us. Now, granted, you're gonna have us do an onboarding. Like I'm not saying it's free, right? Because with any change, there is a cost to it. But the way that our contracts work is for the first 90 days, we want to run a partnership period where we don't send you an invoice, so you can be able to figure out if SaRa's right for you or not. So our goal is for practice owners that work with us always be cash flow positive on SaRa and the remote therapeutic monitoring codes, and we've set up our business to be able to facilitate that in the best way possible. So that's our model. Then it's basically a per CPT code delivered. So if you enroll a patient and they don't get billable for anything, you don't owe us a dime because you can't bill for a dime. And that makes us very, very incentivized to figure out how to fix that, right? And so we are in there with you as close as we can without violating the anti-kickback statute. I wish I could tie myself to collections. I really do. It'd be easier, but I don't look good in orange, so therefore, or jumpsuits in particular. So we're not going to go that route. Maybe that'll change one day, and we'll be able to. But for practice owners who want to get an idea of what could this mean for my clinic, if they go to SaRaHealth.com, we have a ROI calculator on our website, so you can put in how many clinicians you have, your different payer sources, all that, and be able to actually see what we think you could generate based on what we've seen in our practices across the country. And then if you're interested from there, just book a demo right on our website. And we'd love to see if there's a way that we could be able to serve you and your patients. If not, whether that's in the demo, we figure that out, or at the end of 90 days, we shake hands and that's it. I think the being a physical therapy practice leader today is an extremely hard position, but one that we need to support in so many different ways because our population is only getting older. It's only becoming more expensive to become a physical therapist, right? There's a lot of these macro conditions that are not making it easy to run a rehab business, and we're not going to be one of the things that further deflates that. Just not going to do it. It's philosophically how we believe. And so yeah, SaRaHealth.com and see if it could be worth juice worth the squeeze, and book a demo, and it's we go from there.
That's awesome. I respect that approach. I appreciate that, how you frame that and how you're approaching it. And that is cool to be able for clinics to start for 90 days, only pay when billing is being done. So it's not a percentage, right? So it's not like a billing company, but it is sort of like a billing company that you only collect, you only get paid when there are some collections coming into the clinic. So it removes the risk from the practice owner. So I like it.
Yeah, well, just because my legal team would not be happy if I didn't say so. We can't attach ourselves to collections in perpetuity. During that first 90 days, we can be much more flexible, so you can test your entire payer mix. So like if you're in Austin, right? So I would expect for you to see really good reimbursement from United, Humana, Blue Cross Blue Shield of Texas, Medicare for broadly. So I would already know going in, like, all right, yeah, Garrett's going to do really well here. TRICARE, he's not going to get paid for, but oh, he has some Tri-West people in VA, like, okay, he's going to get paid for there. So we have a good idea of that going in. But we attach ourselves to the documentation, right? So if you can bill for it, we've done our job, because we wouldn't give you something to bill unless we could create the documentation based on the rule set. So
Yes.
I don't want anyone to come in with a incorrect view on it. So I hope you don't mind that. I just made that.
That's good.
Sweet.
It's important, especially with billing and compliance, important to be precise. It's worth taking the extra minute to get it clear. So yes, you're not, and I apologize for misspeaking there also. But so it's not, yeah, it's not based on collections, but it's based on billable activities that there's a high degree
Correct.
of likelihood that revenue would come in, and it doesn't eliminate, but it dramatically reduces the risk to a practice owner. So yeah, well said.
And now that we work with,
clarify that, I don't want to leave anyone with any false impressions either. So or unclear expectations. So yeah, that's all.
I appreciate it, and yeah, I mean, we got a pretty good idea now. Like the likelihood that you're going to be in a state that we haven't seen yet is pretty low. And so yeah, the not we're still learning about new payers every day. Like, I didn't know that Arizona Medicaid pays really well for these codes. That was a new one that I did not know. So we're still seeing surprises, but yeah, at this point, based on your state and your payer mix, we'll be able to give you a pretty darn good idea of what to expect.
Well, it's nice that was a pleasant surprise rather than an unpleasant surprise. So that's okay. That's good. And just so for everyone, it's for SaRaHealth.com. It's SaRaHea, SaRa Health. There's no extra H on the end of Sarah.
There's no extra H. My little sister, her name's Sarah. She thought it was named after her, but as we talked about, it's an acronym. Stands for the Strength and Resilience Assistant. So creating stronger, more resilient patients and practices. It's I guess a shtick of mine. My first company I created was called myrivet.com, which stood for my resource files, my books and supplies, my teacher recommendations. When I launched it in college, my next one will also probably be an acronym. Like, at this point now, it's it's a trend line. You just gotta stick with it. But that's SaRa Health, just SaRaHealth.com.
Nice, I like it. Well, thank you, Steven, for coming on and sharing your work with us, and everybody listening. Thank you for tuning in. I hope that this exposed you to perhaps some new ideas, new processes, a new technology platform, and I think most importantly, encourage you to think about ways to deepen your relationships with your patients, because that's going to lead to better outcomes, for them and for your business long term, right? That's the best thing we can do is provide the most value, the best service. It's going to come back to you in the long run for sure. So
yes, it will.
Again, Steven, thanks everyone for tuning in, and we will see you on the next episode of the Undercurrent podcast.